Good morning, everyone. We are here at the ESC Heart Failure in Paris and I have the great pleasure to interview Dr. Butler from US. We have just seen the results of the CHART-1 trial, so we're going to talk a little bit about stem cell therapy. And can you just tell us or summarize the results and your impression about them?
Yeah, so the stem cell therapy obviously has been around for some time and there's continued interest. This was an echo sub-study of the CHART-1 trial, which had originally sort of shown that the bigger the LV size, the better the trial benefit. And in this particular trial, they looked at baseline LV function and all the parameters of LV function. The bigger the heart, the lower the ejection fraction, the higher the risk those patients were at. And then the stem cell therapy tended to work better when your heart function was relatively not only ejection fraction, but remodeling, the dilatation of the heart, all were predictable of how you will respond. Now, what was very interesting was that in this trial, the investigators were allowed to give more than one injection, all the way up to 20 injections, depending on a whole bunch of criteria. So the first part, that the worse the remodeling, the higher the response, was not really a surprise. One, you would expect that. You've seen perhaps with some other therapies also. But what was surprised was that the more the injections, the less the benefit. And you would have expected that more is probably good, so more injections would be better, but results are what they are.
Okay, well, I won't ask you for the explanation about this, which might be very difficult for us. But is this trial, how was the delivery? And all these trials, did they have different way of delivering stem cells? And do you think this might affect the response?
So this trial was actually very interesting because they had sham procedures. So many of the trials don't have sham procedures. So what they did was that people got intracardiac injections of the cells. So they could, as I said, give all the way up to 20 injections. But there was a sham procedure, so the people who were in the placebo arm also actually got a catheter into their left ventricle, but they did not get sham injection. So they only got a sham catheter into the LV. So I think it's a step up. Now, the first thing that you asked, was why was more cells related to poorer outcome? One hypothesis could be that these cells, when you inject them, there is some volume that goes in. So, even if it's a half a cc or whatnot, by the time you're talking about 20 injections, you're actually giving a lot of intracardiac volume along with the cell. So is there a possibility that giving too much of the injections into the heart is not good for you? Now, you could have answered that question if the sham was also injections. And if you would have actually given intramyocardial injections of, say, just saline with sham, you would have answered that question. But nevertheless, I think it still is a good design, and at least there was a sham procedure. However, there are intracoronary injections, there are retrograde sinus injections, and then there is sort of growing interest in forgetting about giving the injections directly into the heart, and there are reasons why one can postulate that maybe just even giving intravenous cells could be good enough.
Okay. That's very interesting, and I mean, I'm new into this business, so it's very good for me to learn from all these experts. So how you would design the next trial? So which would be the next step? Because I think, all these trials have been covering the design aspect has been more or less complicated, and then how would you improve it?
Sure. So, obviously part of the answer depends on what kind of stem cell you have and what kind of patient population you want to go into. But I can give some generic comments. So one is, whenever you do a trial design that requires injection into the heart, makes it a little bit more complicated trial, whether it's intracardiac injection, whether it's intracoronary injection. The beauty of the intravenous injection is that if the therapy works, one can imagine in the long run, it could be an outpatient therapy because you're giving it intravenously. So that is one aspect to keep in mind. The problem with the stem cell therapy is that there are multiple reasons why a therapy may not work, even if it's a good therapy. So one question is it realistic to just give one injection? And by one injection, I don't mean one injection in the heart or versus 5 injections, but just one time. This is like, taking ACE inhibitor, one tablet, and expecting things to get better, right? You have to do it recurrently. So should we be giving these therapies every 4 weeks, every 3 months, every 6 months? I don't know. So what is the recurrent injection? The second issue is obviously the route of administration. We talked about that a little bit. And then the third issue is how many cells. So regardless of what cell, I know there's a debate about cardiopoietic cells, mesenchymal cells, this, that, that, but regardless of what kind of cells, it is how much do you give it? Do you give it 1.5 million per kilogram, 2 million, 1 million? So all of those questions makes it very, very difficult to answer the question, what is the ideal design? In my opinion, there are data to suggest that after you give the injection, and if you tag it with some sort of molecular imaging technique, in a month or so, 98% of the cells are gone. But now there are very interesting data coming out that you see some, immune modulatory effect with these cells. Your NK cells go down and whatnot, and that kind of sort of starts returning after about a month. So doing a clinical trial with giving intracardiac injections on a monthly basis is not going to happen. So I think that probably an ideal thing would be to do a trial where you give recurrent injections, say every 3 months, times 3 or something like that, but see if you can give it intravenously, and the paracrine effect systemically may benefit management of heart failure. I don't know.
Yeah, I think you covered so many things, and I will have just the last question for you.
Yes.
So, do you think that the etiology of the disease that is causing the heart failure may be relevant?
So 2 things to that effect. One is that for many therapies like beta blockers and CRT, we have learned that reverse remodeling is better for non-ischemic than ischemic cardiomyopathy patients. The second issue is that the stem cell therapy, it is making your dysfunctional myocardium work better, but we don't necessarily have evidence that it gets rid of the scar. And non-ischemic patients have less scar than ischemic patients. So at least theoretically, non-ischemic patients may actually be more responsive to stem cell therapy, despite of the fact that the vast majority of the studies have been done in actually ischemic cardiomyopathy patients. And this is a legacy of the initial trials that were done for acute myocardial infarction. So I would say that etiology probably doesn't matter ischemic or non-ischemic, but you just want to make sure that you're not giving a therapy to a person with a very large scar burden, because that is likely not to reverse.
Okay, thank you very much for your time, and
My
we're
pleasure.
happy to see you at the next CVCT in
My
Washington.
pleasure.